All right. So I have an hour this morning, but I think we can probably finish in about 1 minute as long as we get through this slide. So Alzheimer's disease is a neurodegenerative disease. It's the most common cause of dementia. So that's what Alzheimer's is. That's the title of my talk. Any questions? All right. Let me tell you a little bit about myself. So I studied medicine at Duke, where I also did all of my postgraduate medical training. I did a master's in public health at UNC while I was down in North Carolina, and I've been up here since 2009. So I'm about 3.5 years into my first real job, and I'm having a great time with it. I work at Reliant Medical Group, which used to be called the Fallon Clinic, and my main office is attached to St. Vincent's Hospital here in Worcester. I also work in Westboro, and I also do a rehab program with Millbury Healthcare. I put on there people that I've taken money from, because I think that's an important thing to know whenever you're listening to someone give a talk. I have not taken any money to be here this morning, so this is just my service to this event. Those are the 3 most important brains in my life. That's my wife, Amy, and my daughters, Nevaeh and Alexis. And I have sort of an impossible goal for today, which is to try and answer the question, what is Alzheimer's disease, in an hour. These are just 2, and this is Impossible to read by Patty Griffin, Alvin Martin. That's Mission Impossible. But whichever way you tend to swing in terms of your imagery, you pick your favorite. So I do have some goals, though. I'd like to try and define what dementia is, give you a quick idea of what Alzheimer's disease looks like from different perspectives, and talk a little bit about what we know, which is not much, about what causes Alzheimer's, and then talk about the process of diagnosis of Alzheimer's, because this is something patients often have a lot of questions about, and then briefly talk about what Alzheimer's means. I have just one viewpoint on that, but hopefully you'll learn something from the talk that you didn't know before. It's always hard with a group this big. A lot of you have probably been interested in Alzheimer's for some time and know a lot about it, and you may not hear too much that you don't know. And then other people are exploring this for the first time, so you have to kind of pick a level. I also, as one of my goals, aim to leave a good chunk of time for questions and answers at the end, because I found that the Q&A sessions in this kind of talk are often the most exciting and fruitful. So to begin, we should talk about what is dementia, right? So one of the most common questions I get in clinic is, what's the difference between Alzheimer's and dementia? And the answer is that dementia is a more general term, and Alzheimer's is a specific type of dementia, or a specific cause of dementia. So dementia is chronic, i.e. long-standing, deficits in memory, and at least one other brain function, language, problem solving, of enough severity to interfere with activities of daily living. So that makes you change your routine, makes you implement supports that you wouldn't have to otherwise implement. So that's the clinical definition of dementia. Dementia can be caused by a lot of different things, and I'll have a slide about that in a second, but Alzheimer's is the most common cause of dementia. It's just 50 to 60% of dementia is pure Alzheimer's disease. If you include Alzheimer's mixed with vascular dementia, you're talking about 60 to 70% of dementia. So it's most of what we see in people who develop dementia. So what else causes dementia? And this is one of the questions that myself as a neurologist always ask when I'm seeing someone who has some memory difficulty in clinic, is what is going on and what might be causing that. So as I said, Alzheimer's is the most common cause of dementia, but you can have vascular disease on the brain, which is essentially accumulated stroke damage, either little tiny strokes that a person may or may not know that he or she has had, or big strokes that can cause a dementia-type picture. One of the most common things that we see is a mixed picture with some neurodegenerative component, usually Alzheimer's, and some infarct component. There are many other neurologic diseases, both infectious, immune, inherited, that can cause a dementia picture as well. So multiple sclerosis can lead to dementia, and some people suffer from that. Lots of different inherited neurologic disorders can end with dementia. Down syndrome ends with Alzheimer's dementia, usually in the 40s. Different infectious diseases, HIV and syphilis, can produce a dementia picture. Neurosyphilis used to be one of the most common causes of dementia if you go back 100 years ago. It's exceedingly rare now in the first world, but it still remains on the list of things that we think about. And then another common cause of dementia is chronic alcoholism, and that may or may not be related to vitamin deficiencies that can go along with that as well. And B12 is the most common vitamin deficiency that we see. So in addition to those disparate causes, there's also other neurodegenerative dementias. In other words, other dementias where the brain cells just stop working right and drop out. Frontotemporal dementias is a group of specific disorders that have a different clinical presentation than Alzheimer's disease, and a different imaging presentation, but again are neurodegenerative dementias. Dementia with Lewy bodies is a disease that's related to Parkinson's disease, in which you get a different kind of neurodegeneration that's accompanied by movement difficulties. And then CJD, which is Creutzfeldt-Jakob disease or a prion disease, is related to the fabled mad cow disease, but most cases of CJD don't have anything to do with cows. They can occur sporadically. It's a rare, but something we see once a year or something in a general neurology practice. We'll encounter a patient with this diagnosis. So another question that often gets asked is dementia part of the normal aging process? And there's a lot of different ways you can stand back and look at this question. And historically, there's sort of been a bias that yes, people do end up becoming senile. And for a long time prior to 1980, there was a differentiation between senile dementia and pre-senile dementia in the medical literature, and that's kind of gone away in recent years. The current answer for the advocacy community, i.e. the Alzheimer's Association, and the scientific and medical communities, is that no, dementia is a common thing that happens as we age. Okay, once you're 85 plus, at least a third of your co-patriots in terms of age are going to be demented, statistically, epidemiologically, but it is not inevitable. Lots of individuals make it to 95, 103, and do not have dementia. So it's certainly not an inevitable part of aging. This is a graph we're trying to explain. So this is age in years, going from 40 to 90, and performance on a global cognitive instrument, a neuropsychological test. And as you can see, statistically, we do tend to perform worse cognitively as we get older. So this is the mean of performance at any given age, and there's an age-related decline across the population. But if you look at any given age, 70, there's still 0 is sort of not being impaired. There's still a lot of people unimpaired, although slightly dwindling in number at any given age as you go forward. So it's not inevitable that people lose their cognitive capacity as they get older. In the 17 and 1800s, dementia was an even broader term than it is today. And the term dementia was used to basically encompass any kind of organic or psychiatric illness that incapacitated someone from a psychosocial standpoint. In the late 1800s, this narrowed to be closer to what we use when we say dementia today, which is specifically cognitive decline that is disabling to someone. All right, so now I'm going to have some audience participation. I need everybody to stay awake. So we're just going to do this by a show of hands. All right, we're here to talk about Alzheimer's disease. So who was Alzheimer? All right, so was Alzheimer a patient? Many probably already know. Was Alzheimer a pathologist? You might not know this. You got at least one. A fictional character? No. A psychiatrist? Yes. All right. Everybody knows that. So that's the man there. And who's that? Yeah, the woman. Yes. The woman is the index patient. This is the woman that Dr. Alzheimer wrote up in a paper in 1907. So this is Auguste D, last initial used in the paper. And she entered an asylum at the age of 51 in Germany. And she was dead 5 years later with dementia and psychosis. And ultimately, he sent that brain to a pathologist colleague of his. And then in 1907, he presented this case as an early onset dementia case. And he said, this looks like something that happens to people who are much older, but this happened to a 51-year-old person. And in that brain, the pathologist described plaques and tangles, which we'll get to in a second, which are the typical changes in the brain seen in Alzheimer's disease. And the thing that was unique about Alzheimer's description was the early onset of this. So Alzheimer didn't really describe anything new, per se. He just described a case where this happened sooner than it usually happens. Plaques and tangles had already been described by other pathologists, both in Europe and America at the time. However, a new disease was necessary to obtain a research grant from the German government. And so he had to spin this as a new disease and ultimately ended up carrying his name. And the name has stuck since before 1920. That's been widely used. So within the last 30 or 40 years, though, we've started calling more things Alzheimer's disease. Because in the 20s, 30s, 40s, even 50s, 60s, Alzheimer's disease was limited to those patients like the one that Alzheimer described, who had early onset dementia, at least dementia before the age of 65. And then what we started realizing in pathological studies is that the more typical, quote-unquote, senile dementia that was occurring later in life looked identical to the early onset Alzheimer's in terms of the brain pathology. So something was happening different in terms of timing, but it looked like this was the same disease process. And thus forth, we've used the term Alzheimer's disease to describe these typical pathologic changes that we see in dementia, whether they are earlier in life or later in life. And that's how Alzheimer's disease got to be the most common form of dementia. So there are a couple different clinical staging systems out there for Alzheimer's. Another favorite question that people ask me when they come to clinic is, what stage do I have? And I usually tend to find that question not very well serving for the patients or families. I think that if you go to the Alzheimer's Association website, I just cut and pasted this off their website, and you can click on these links and there's nice descriptions of these 7 stages of progression. I think it's informative as an educational piece to learn what happens to people as this disease marches forward. But it doesn't necessarily mean that everybody's going to behave that way. And it doesn't necessarily mean that everybody's going to get to every stage. You have to remember that Alzheimer's disease is, by and large, as we'll see several times in the talk, a disease of late life. And we all come here with different life experiences, but we all have at least one thing in common, which is that we're all going to die. And most of us are going to get sick and then die from something. And many more people die with Alzheimer's disease before getting to the very end stages of Alzheimer's disease than die at the very end stages of Alzheimer's disease. So everybody's journey through this is a little bit different. These are some signs of dementia, and these are signs that are specific to Alzheimer's type of dementia as common ways that it can present. We'll take a look at that for a minute. Again, this information is also on the Alzheimer's Association website. Raise your hand if you know what a website is and can access one. We finally hit the point where you can give a talk, and regardless of the age of the audience, the majority of people have web access. So I think this is great in terms of distributing patient education materials. But all of these things are ways that sometimes patients or family members first have clues that something is going on. All right. So I want to talk a little bit about insight in dementia, because this is a term that I will use a few different times. Insight is the appreciation of one's own difficulties or deficits in brain functioning. And insight is often impaired in Alzheimer's dementia. So another question that often gets asked is dementia part of the normal aging process? And there's a lot of different ways you can stand back and look at this question. And historically, there's sort of been a bias that yes, people do end up becoming senile. And for a long time prior to 1980, there was a differentiation between senile dementia and pre-senile dementia in the medical literature, and then that's kind of gone away in recent years. The current answer for the advocacy community, i.e. the Alzheimer's Association, and the scientific and medical communities is that no, dementia is a common thing that happens as we age. Okay? Once you're 85 plus, at least a third of your co-patriots in terms of age are going to be demented, statistically, epidemiologically, but it is not inevitable. Lots of individuals make it to 95, 103, and do not have dementia. So it's certainly not an inevitable part of aging. This is a graph we're trying to explain. So this is age in years, going from 40 to 90, and performance on a global cognitive instrument, a neuropsychological test. And as you can see, statistically, we do tend to perform worse cognitively as we get older. So this is the mean of performance at any given age, and there's an age-related decline across the population. But if you look at any given age, 70, there's still 0 is sort of not being impaired. There's still a lot of people unimpaired, although slightly dwindling in number at any given age as you go forward. So it's not inevitable that people lose their cognitive capacity as they get older. In the 17 and 1800s, dementia was an even broader term than it is today. And the term dementia was used to basically encompass any kind of organic or psychiatric illness that incapacitated someone from a psychosocial standpoint. In the late 1800s, this narrowed to be closer to what we use when we say dementia today, which is specifically cognitive decline that is disabling to someone. All right, so now I'm going to have some audience participation. I need everybody to stay awake. So we're just going to do this by a show of hands. All right, we're here to talk about Alzheimer's disease. So who was Alzheimer? All right, so was Alzheimer a patient? Many people probably already know. Was Alzheimer a pathologist? You might not know this. You know, at least one. You know, a fictional character. No. A psychiatrist. Yes. All right. Everybody knows that. So that's the man there. And who's that? Yeah, a woman. Yes. The woman is the index patient. This is the woman that Dr. Alzheimer wrote up in a paper in 1907. So this is Auguste D, last initial used in the paper. And she entered an asylum at the age of 51 in Germany. And she was dead 5 years later with dementia and psychosis. And ultimately, he sent that brain to a pathologist colleague of his. And then in 1907, he presented this case as an early onset dementia case. And he said, this looks like something that happens to people who are much older, but this happened to a 51-year-old person. And in that brain, the pathologist described plaques and tangles, which we'll get to in a second, which are the typical changes in the brain seen in Alzheimer's disease. And the thing that was unique about Alzheimer's description was the early onset of this. So Alzheimer didn't really describe anything new, per se. He just described a case where this happened sooner than it usually happens. Plaques and tangles had already been described by other pathologists, both in Europe and America at the time. However, a new disease was necessary to obtain a research grant from the German government. And so he had to spin this as a new disease and ultimately ended up carrying his name. And the name has stuck since before 1920. That's been widely used. So within the last 30 or 40 years, though, we've started calling more things Alzheimer's disease. Because in the 20s, 30s, 40s, even 50s, 60s, Alzheimer's disease was limited to those patients like the one that Alzheimer described, who had early onset dementia, at least dementia before the age of 65. And Then, what we started realizing in pathological studies is that the more typical, quote-unquote, senile dementia that was occurring later in life looked identical to the early onset Alzheimer's in terms of the brain pathology. So something was happening different in terms of timing, but it looked like this was the same disease process. And thus forth, we've used the term Alzheimer's disease to describe these typical pathologic changes that we see in dementia, whether they are earlier in life or later in life. And that's how Alzheimer's disease got to be the most common form of dementia. So there are a couple different clinical staging systems out there for Alzheimer's. Another favorite question that people ask me when they come to clinic is, what stage do I have? And I usually tend to find that question not very well serving for the patients or families. I think that if you go to the Alzheimer's Association website, I just cut and pasted this off their website, and you can click on these links and there's nice descriptions of these 7 stages of progression. I think it's informative as an educational piece to learn what happens to people as this disease marches forward. But it doesn't necessarily mean that everybody's going to behave that way. And it doesn't necessarily mean that everybody's going to get to every stage. You have to remember that Alzheimer's disease is, by and large, as we'll see several times in the talk, a disease of late life. And we all come here with different life experiences, but we all have at least one thing in common, which is that we're all going to die. And most of us are going to get sick and then die from something. And many more people die with Alzheimer's disease before getting to the very end stages of Alzheimer's disease than die at the very end stages of Alzheimer's disease. So everybody's journey through this is a little bit different. These are some signs of dementia, and these are signs that are specific to Alzheimer's type of dementia as common ways that it can present. We'll take a look at that for a minute. Again, this information is also on the Alzheimer's Association website. Raise your hand if you know what a website is and can access one. We finally hit the point where you can give a talk, and regardless of the age of the audience, the majority of people have web access. So I think this is great in terms of distributing patient education materials. But all of these things are ways that sometimes patients or family members first have clues that something is going on. All right. So I want to talk a little bit about insight in dementia, because this is a term that I will use a few different times. Insight is the appreciation of one's own difficulties or deficits in brain functioning. And insight is often impaired in Alzheimer's dementia. This function, for lots of different reasons, often impairs our insight. So the most common one that we have experience with earlier in life is the "I'm not drunk" phenomenon, right? If you're in a social situation and someone has had too much to drink and is convinced that they can drive home, they're the last person to recognize that they've had too much to drink. And that same kind of thing can happen in Alzheimer's, where the memory can be slipping away, and the person who's affected can be the last person that will recognize that that's going on. This is not invariably true, but it's commonly true. And often this gets blamed on defensive-ness or denial. And defensive-ness and denial are both real and both happen. But a lot of times it's neither of the above. A lot of times it's just not evident to the person who's having difficulty with their memory and their other cognitive functions. So insight is usually impaired in Alzheimer's disease. And there's I want to say rule of thumb, but I hate that expression because of its origins. So there's a short heuristic that we use in clinic, that if a patient walks in and says, "Doc, I'm really worried I have Alzheimer's disease," before I do any assessment and any history and look at any MRIs or anything like that, chances are they don't have it. And if a patient is brought into clinic by their spouse, and the spouse says, "Doc, something's just not right," and the patient says, "What are you talking about? Everything's fine," they probably have Alzheimer's disease before I do anything else and look their studies and exam and all this kind of stuff. So that the lack of insight is a challenging piece to negotiate. Much more so from a family and caregiver standpoint than it is from my standpoint. I get the luxury of seeing people for a brief, defined period of time periodically. I don't have to go home and live with all of the patients that I see that you guys do. And that negotiating and dancing around the lack of insight and trying to respect where people are at, but respect reality as well becomes a real challenge that we all face. All right, so if I'm going to talk about what is Alzheimer's disease, I should show you a brain slice. So this is a pathological preparation of cerebral cortex, and the two famous Alzheimer's disease findings are here on one slide. So don't ask me what the stains are, because it's been a long time since I've stained anything with a microscope. But this red staining material is a plaque, and within the neurons, these purple staining items are the neurofibrillary tangles. So the combination of plaques and neurofibrillary tangles, widely distributed throughout the brain, is the pathological hallmark of Alzheimer's disease. That's how you diagnose Alzheimer's at autopsy. All right, so the other thing that you can see aside from plaques and tangles, so plaques and tangles are without deviation or variation. They have to be there. You don't have plaques and tangles, you don't have Alzheimer's disease. Usually don't run straight to a brain biopsy or autopsy because people aren't afraid to get there. But the other thing that you can sometimes see in Alzheimer's disease is atrophy or loss of brain volume. So this is usually not evident early in the disease when you're trying to make the diagnosis. So this is usually something you can see later on down the road in people clinically. But this is a normal gross brain specimen viewed from the side, cerebellum and back, fronts up here, eyeballs here, nose here. And this is a late-stage Alzheimer's patient. And what you can appreciate is the space opened up here. There's a lot of empty space where there should be brain, okay? And this is a coronal, i.e. down the front, MRI slice, coronal T1 MRI, looking at a normal brain and an Alzheimer's brain. And specifically what they point out in this is that the brain shrinkage is not indiscriminate and global. It's not that all parts of the brain shrink at the same rate. You specifically get shrinkage in a part of the brain called the hippocampus, which is outlined in red here. So this is a normal hippocampal volume outlined in red here. And then in a late-stage Alzheimer's patient, you see gross shrinkage of that hippocampal volume. And the hippocampus is crucial for processing memory, for encoding memory, which goes along with having difficulty with encoding memory in the progression of Alzheimer's disease. So CT scans and MRIs can show the atrophy of Alzheimer's disease and advanced disease, but they are often normal early in the disease. So if someone comes to me and I think they may have early Alzheimer's disease and their MRI is normal, that is entirely consistent with them having early Alzheimer's disease. You don't see atrophy changes, atrophic changes until much later in the illness. We often do MRIs or CTs to look for other things going on, but you can't spot Alzheimer's disease on a routine brain scan. There are some scans out there that do fairly reliably demonstrate changes in Alzheimer's disease versus normal brains. So this is a fluorodeoxyglucose PET scan. So this is a PET scan that looks at brain metabolism, basically. So brighter, warmer colors, it's just like a weather map. So red is hot, lots of activity. Yellow's in the middle, and then the cooler colors, green, blue, are less brain metabolic activity. And you see a relatively symmetric decrease as you go from moderate Alzheimer's disease to severe Alzheimer's disease. This is from literature where DAT stands for dementia of the Alzheimer's type, which is a term that's used in the literature. And then this Pick's disease is one of the frontotemporal dementias. And then this is someone who has Alzheimer's but also has aphasia in the left hemisphere of the brain. Whenever you look at scans, it's backwards. It's like looking at a mirror. This this is the left side, this is the right side, and the left hemisphere of the brain is even cooler than the right, which goes along with the language functions in the left going down. So regular PET scan or glucose PET scanning can be helpful in the diagnosis of Alzheimer's, although it is not widely used clinically. It's not a machine that's at most hospitals, and it doesn't greatly lead to the utility of clinical care. And we can talk about that during question and answer, but it is used in research settings fairly frequently. There's also more specific PET ligands that can look at beta amyloid. And here, one of them is called the Pittsburgh B compound. And here you see these are subjects normal with very mild cognitive impairment getting to more severe cognitive impairment and full-blown Alzheimer's disease clinically. You see this high degree of activity for binding to the beta amyloid plaques that are present. So there are specific PET scans that can image beta amyloid in the brain. And again, for research purposes, this is helpful for looking at how much Alzheimer's disease pathology someone has without going to brain biopsy. But again, this is not a test that is widely used for clinical purposes, so most patients don't get this. So what does Alzheimer's do, or what's actually going on in Alzheimer's? So this is kind of like the elephant analogy. It's hard to, Alzheimer's disease is the elephant, and if you are encountering an elephant in a dark tent, you sort of think that it looks like whatever you happen to be touching or happen to be near. And you can look at what's going on in Alzheimer's a lot of different ways and get pieces of the answer. But I think that a completely coherent picture of all of the pathways of what is happening in Alzheimer's in the brain cells and why is not fully understood. And that's why there's whole research institutions and hundreds, well, not hundreds, and tens of thousands of scientists around the world who are actively working on this question. So I'm not going to give you the answer here, but we can talk a little bit about some of the major themes of what's happening inside brain cells as Alzheimer's disease goes on. So we'll talk about beta amyloid and tau, which are two important proteins that are implicated in Alzheimer's pathology and progression. And we'll talk very briefly about oxidative stress and insulin. Actually didn't put more slides in there on cell death after I made this outline, so just ignore that last one. Beta amyloid is a protein that we don't fully understand its natural purpose, but it seems to be important in forming connections from one brain cell to another. So our brains are networks, and the way that we think is by brain cells communicating with one another in these networks. And these synapses are formed throughout life. The vast majority of our synapses form very early in life, but there continues to be some plasticity in the brain, which is something relatively recently appreciated in neuroscience throughout life. And the synapses that we have change their dynamic nature as well. There's processes called long-term potentiation and long-term depression, which change the sensitivity and dynamics between which neighboring brain cells talk to one another and send signals to one another. And the inability to modulate these connections and form these connections is part of what happens in Alzheimer's disease. Okay? So beta amyloid, the amyloid precursor protein, which is a protein that lives in the cell membrane, seems to be important in forming these connections between cells. And then through various events, there's enzymes that cut off pieces of this protein, illustrated as scissors here, and you get these free-floating chunks of a protein called beta amyloid. And these free-floating chunks of beta amyloid stick together in gloops, and then the gloops stick together in bigger gloops, and the big old blobs of beta amyloid are the plaques that you see under the microscope. So when you look at the microscope, back to the slide with the plaques, these guys, the primary constituent of those plaques are these aggregates of beta amyloid. And so the beta amyloid story is a very active one. in June of this year, there was a series of news articles about, I think it was a Swedish study where they were looking at a beta amyloid vaccine. So you remember reading about the vaccine for Alzheimer's disease. But people are looking at all sorts of different ways to try and send things into the brain to clean up these beta amyloid plaques. And one of the fundamental questions is, are these beta amyloid plaques a cause or an effect of Alzheimer's disease? And we don't quite know the answer to that. There seems to be some toxic properties of these free chunks of beta amyloid that float around. But we actually think that the plaque formation may be a natural protective mechanism and not really the problem itself, but just evidence that the problem is going on. And so it's yet to be shown that we can go in and clean out the beta amyloid and that fixes the disease process, but it's an ongoing active area of research. So beta amyloid is one, if you want it to sound like you know what you're talking about for Alzheimer's science, you gotta know beta amyloid. The other one you gotta know if you want to sound like you know what you're talking about is a protein called tau. Okay, so the tau protein is part of an assembly of what is called a microtubule. So if you don't, well, probably for most people, microtubules weren't a big subject in high school biology because we didn't know very much about microtubules until the last few decades. But microtubules are part of what's called the cell transport mechanism. So the thing about brain cells and neurons in general is that they're really big cells. They're huge. Okay, if you think about most cells, like skin cells, there are hundreds of them, just on the very tip of my finger. But nerve cells can have parts that are really, really big because they have to stretch from point A to point B to form this wiring that forms the network. So the longest cells in our body are the nerve cells that start in the spinal cord and go out to your big toe. And you've actually got one cell that goes from the spinal cord all the way to the big toe. And in the brain, you've got cells that go from one side of the brain to the other, and they have these long projections called axons. And so brain cells are hard to maintain, right? Think of like the Bay Bridge, right? Bay Bridge is hard, in San Francisco is hard to maintain because it is so darn long, right? So the longer you make something from an engineering standpoint, the easier it is for you to have some breakdown. And part of the maintenance mechanisms for these cells is to have transport mechanisms that take things all the way from the cell body, which is sort of like the command and control center from a biology standpoint, all the way out to all these places the cells have to go, which can be centimeters away, really big in cell speak. And one of the important parts of that are these microtubules. So the microtubules are like freeway lanes. And they actually have proteins that can carry nutrients down the microtubules, can carry waste, can carry proteins. All the repair mechanisms for the cell need to go back and forth from the cell body out to all the extensions via these microtubules. So if you start messing with the microtubules, you start messing with the health of the cell. Okay. So we don't fully understand why this happens, but one of the proteins that's important for maintaining the microtubules themselves is this protein called tau, which is schematically illustrated by these little wormy things here. Okay? And the wormy things help hold the microtubules themselves together. And in Alzheimer's disease, you start losing the association of tau with the microtubules, and the tau itself starts accumulating, much like the beta amyloid starts accumulating. And you end up with these tau accumulations, and these guys are these guys. So the tangles are mostly made of tau. So now you take the two things that we've known for 110 years are associated with Alzheimer's when you cut the Alzheimer's brain and put it under the microscope, and we now know the major protein constituents of those two things, which is great, but it's only gotten us part of the way to understanding this, and there's still a lot to be figured out. So that's the tau story. Tubules to tangles. All right. I'm not going to talk too much about oxidative stress, mostly because I'm not a scientist and I don't want to say something that's incorrect. But there's been a lot of research on oxidative stress, which, so oxidation, reduction, basic chemistry, if you have oxygen species that don't have the right number of electrons, they're very potently toxic to tissues that they touch. And these oxygen species are produced as a byproduct of cellular metabolism. So when the cells breathe, as it were, one of the things they produce as a waste product is these oxygen radicals. And then the cell has a mechanism to clean up the oxygen radicals or detoxify. And when it doesn't detoxify, then you have what's called oxidative stress. And for decades, the oxidative stress hypothesis has been one of the things being investigated as to what's the primary thing happening in Alzheimer's. And the same thing has happened in Parkinson's and a lot of other neurodegenerative diseases. This has led a lot of people to want to take antioxidants to say, does this actually slow down or prevent Alzheimer's? And the answer is we don't really know. So there's some epidemiologic data that show that people who eat a diet rich in antioxidants may have a lower incidence of Alzheimer's disease. But data like that is always fraught with a lot of confounders because you're sort of not looking at something in a prospective manner where you're controlling anything. You're going back and saying, oh, I see this is associated with this. And any kind of data where you look at populations and try and make associations, it's very easy to miss the boat, that there's something you're not seeing that can be explanatory for that apparent link. Or the phrase that we always use is that association does not imply causality, right? Just because you have two things that tend to go together doesn't mean that you can do that any better. So while antioxidants may protect against Alzheimer's, clinical trials of giving Alzheimer's patients high doses of antioxidants have been disappointing. It's another ongoing area of research. This is an area of research that has become popular lately, which is what is the link between insulin metabolism in Alzheimer's and glucose signaling in Alzheimer's. So we know that insulin resistance, the changes that happen in glucose signaling within the cell that occur in diabetes, expose cells to more oxidative stress. And there's mounting evidence that there's a connection between diabetes and risk of Alzheimer's disease. And this has got serious implications for the world, really, the first world, because of the burgeoning obesity epidemic and the accompanying burgeoning epidemic of type 2 diabetes. And we may be teeing ourselves up for even a much worse Alzheimer's situation than we thought by sort of neglecting this aspect of general body health. Again, the brain is a sort of a sentinel organ for the body, right? One of the most common things that happens in the hospital, especially as we get older, is people come into the hospital, they get sick, for some reason they have a urinary tract infection, they have pneumonia, and they get really confused. Well, they don't necessarily have Alzheimer's disease or something going on, but when the body is not optimally working, the brain tends to go downhill in terms of functionality. That's what I just described as what's called delirium, when you're sick and you get cognitive problems. But over the long term, it may be that general health problems like insulin resistance or diabetes are priming the pump for the neurodegenerative processes that look like Alzheimer's disease. Inflammation is another area of research. There's been some trials of anti-inflammatory drugs to prevent Alzheimer's disease. Results here are mixed. There's no conclusive evidence that we should all be taking naproxen to try and prevent Alzheimer's disease at this point, but it is an ongoing area of research. So what do we know is associated or causes Alzheimer's disease? Well, Alzheimer's disease certainly has some genetic component. In a minority of cases, there's a clearly identifiable genetic mutation that confers risk for Alzheimer's disease. So in maybe up to 10% of cases, there is a mutation in a gene called presenilin 1 or presenilin 2, which predispose people for early onset Alzheimer's disease. In the more typical cases of Alzheimer's, there's this gene called ApoE. So ApoE is a gene that we all have that deals with cholesterol metabolism. And there's a certain, so raise your hand if you know the ApoE story. Raise your hand if you've never heard of ApoE. Wow, okay, so I have a biased perspective here because the gentleman who was the chairman of the neurology department at Duke built his whole career on ApoE. So I've heard this about 600 times during my residency training, and I'm sick of ApoE, but it is an interesting story. So ApoE is a protein that helps in breaking down and forming cholesterol and moving it about in the cells. And there are 4 different versions, really just 3. There's the one doesn't really exist in humans. There's just 3 versions, number 2, 3, and 4. I know that's confusing, but the 3 versions of ApoE are 2, 3, and 4. And you get a copy from mom and a copy from dad. And so you get one copy of ApoE that's 2, 3, or 4, and a second copy of ApoE that's 2, 3, or 4. And what was discovered is that the way you get these copies significantly influences your risk of getting typical Alzheimer's disease later in life. Okay? And so this was groundbreaking work when it was first published. If you look, this is what's called the survival curve. So on this side is the proportion of people without disease. So if you go across this way, it means that nobody has disease. 100% of people are without disease. If you come down on this steep curve, by this point it means half the people have Alzheimer's disease. Okay, so proportion of disease is on the left-hand side, and age is along the bottom. And these numbers, 4, 4, 3, 4, 3, 3, 2, 4, 2, 3, are the copy from mom and copy from dad that you have in this ApoE gene. And we're still not exactly sure what the relationship is, why it happens. But if you have the ApoE4 gene, which is a less effective cholesterol handling gene, you are significantly more likely to develop Alzheimer's disease. If you go to 75, okay, at age 75, 80% of people with 2 copies of 4 have Alzheimer's disease, right? Versus 40%, versus 60% of people with 1 copy of 4, versus only about 25% of everybody else, which is the majority of people. So if you are unlucky enough to have 2 copies, by the time you get to 75, you have an 80% chance of developing Alzheimer's disease. So there seems to be a significant genetic component to your risk of Alzheimer's occurring within your cells. The biggest risk factor for Alzheimer's is age, and this is just a compilation of lots and lots of different studies looking at the incidence, number of new cases per 100 people per year, going from 2 up to 14, depending on what age you're in. As you can see, it's relatively uncommon below 70, versus getting much more common as you get 80 and 85 plus. There are more women than men with Alzheimer's disease, but most, if not all, of that difference is explained purely by the fact that women live longer than men, and your risk of Alzheimer's disease goes up the longer that you live. And then, like I talked about before, there's growing evidence of a link between type 2 diabetes and Alzheimer's. There's growing evidence of a link between vascular disease and Alzheimer's. The theory being that perhaps there's some common inflammatory state that promotes both of these. And there's weak evidence for physical inactivity being associated and diets low in antioxidants being associated. But no one would fault you for getting some exercise and eating a healthy diet. Those are good things to do. All right. We got 20 minutes left, so we'll go quickly through the clinic visit. So how is Alzheimer's diagnosed? Well, it's oft quoted that the only way to know that you have Alzheimer's is to have an autopsy. And that's sort of true. We're pretty good at clinical diagnosis of this. If it looks like Alzheimer's disease to a neurologist that's experienced with Alzheimer's, it probably is Alzheimer's disease. So by going to clinic and having an evaluation consisting of a history, some cognitive testing, and perhaps lab evaluation and imaging, as we'll discuss, you can have a pretty good idea of whether or not this is what you or your loved one is dealing with. In terms of getting a clinical history, when you go to a doctor to say, does dad have Alzheimer's disease, the important things to make sure that are discussed are what's the intellectual baseline of the individual, because you're going to have different expectations for somebody who's had a 4th grade education, speaks English as a second language, and has only spoken that for the last 40 years, than you are somebody who is a professor of English literature. Okay? And so you want to know what the baseline function was when interpreting the tests. And then you want to have subjective and objective change in performance status. A lot of people get very worried about normal age-related changes in cognition or acuity. So it's important to try and figure out, well, what is it that actually isn't lining up, and what's happening, and how much time is that taking in? Are you forgetting to pay bills? Have there been car accidents? This kind of thing. It's also really important to evaluate collateral history, to try and get history from the significant other, from the children, from other people in the community, to get a sense of what's going on, whether this is more of a subject or an object of decline. As I said, the insight piece is often very limiting as the patient relates his or her own history, but the family often tells a very different story. And most of the time, the family's right. Sometimes the family has their own anxieties or concerns that kind of overshadow things, and they don't give people enough credit. It's important to take a medication and medical history as well as a psychiatric history. Depression is common at any age, and if you're depressed, you can look demented even if you're not. So it's important to try and suss that out. Cognitive testing is part of the routine clinical exam. The one piece of caution that I would give here is a frequently used instrument since the 70s was created by a gentleman named Folstein, and it's called the Folstein Mini-Mental Status Exam. And the Folstein Mini-Mental Status Exam is oft quoted in the Alzheimer's literature, and it's used widely in clinical trials to monitor people's progress with Alzheimer's disease. But it's not a great screening instrument for Alzheimer's disease, especially if you have a higher functioning individual at baseline. So the concept that you go to the doctor, they do a mini-mental status exam, and that score is normal, and you're free and clear, and there's no concern for dementia, it sometimes gets propagated by physicians and patients alike. So if you think there's something wrong, you want to look deeper. The instrument that I prefer is called the Montreal Cognitive Assessment. This only takes 10 to 15 minutes to do in clinic. It's available online. I wouldn't encourage you to download it and practice it because it skews your results when you do go to your physician. The gold standard, or the Cadillac plan, is to have a formal neuropsychological battery. So this means going and meeting with someone who is a psychologist who has done specialty training in what's called neuropsychology. And you sit down for anywhere between 3 and 6 hours and put pegs in holes and shuffle cards and do all sorts of other things. Think of lists of words, remember things, and they comprehensively grade your cognitive function over a series of domains, and then they talk to you and take a comprehensive history and write up a report. Sometimes this is covered by insurance, and sometimes this is not. Sometimes this is useful, and sometimes this is not. And I don't want to say anything bad about my neuropsychology colleagues because they do wonderful work and they're very, very helpful. And I would never say to a patient that wanted to get neuropsychological testing, don't do it, it's not worthwhile. I think it usually is. But there are not enough neuropsychologists and enough coverage for this out there for every single patient with memory trouble to have a formal neuropsychological assessment. And so I typically have a discussion with patients and families about whether or not this would really add anything to what we know and what we're doing about it. Sometimes it does. In terms of other lab tests that are done in the diagnosis of dementia, there's a guideline from the American Academy of Neurology that looked at a bunch of laboratory tests and said how much of the time these actually provide something actionable, okay? And the answer is only about 5%, even for the best tests. But the 2 tests that they recommend everybody with cognitive problems get are a B12 level and a thyroid function test, a thyroid panel. Other routine tests just are not very high yield. We used to test everybody for neurosyphilis. That isn't the case anymore because the incidence of neurosyphilis is so low in the American population. But certainly if there's a history of venereal disease or some other risk factor, you do want to look for both syphilis and HIV, as these can both be causes of dementia. You want to look for vascular risk factors, glucose levels, hemoglobin A1C, LDL cholesterol, if there's a vascular component. Genetic testing is not routinely done. I'm happy to answer questions about that in Q&A. There is a relatively new commercially available panel of spinal fluid tests that is pretty good at discriminating Alzheimer's disease from other neurodegenerative illnesses. And there are a select number of cases where this may be useful. But until we have a specific treatment or cure for Alzheimer's, most patients are not getting spinal fluid analysis as part of their routine workup. We will do spinal fluid analysis if there's concern for an immune disease like multiple sclerosis, or there's concern for an infection, or concern for prion disease CJD, those are times when a spinal tap would be part of the workup for dementia, but most patients getting worked up for dementia or Alzheimer's disease do not get a spinal tap currently. So what does Alzheimer's mean for individuals? So there's Alzheimer's is a game changer, right? Because it has the potential to impact some of the things that we as individuals hold nearest and dearest in terms of our autonomy and our independence. And it's a scary thing to think about. So there's often an initial feeling of shock or fear, or that an ambulance has just been dropped on your head when this diagnosis is brought into the room. But life doesn't stop with the diagnosis of Alzheimer's. And especially at the time of diagnosis, there's a lot of life and a lot of cognitive function left for most individuals. So this, I cut and pasted this from the Alzheimer's Association website. This is just an illustration of a campaign of someone who is going forward with their diagnosis of Alzheimer's, not hiding in a dark closet. And I think that's important. I'm going to try not talk too much about treatment and philosophy, because you guys have other talks coming up about caring for the caregiver and dealing with treatments for Alzheimer's disease. What does Alzheimer's mean for society? So right now it's estimated there's about 5.5 million people with Alzheimer's in the US and 35 million worldwide, and this is projected to triple over the next 35, 40 years. And there's a huge cost to this in terms of taking care of all these people and who takes care of all these people. So this has policy implications, and there's a scientific mission of we really want to try and find a way to fix this because Alzheimer's is not a desirable exit strategy from life. As I said before, none of us live forever, but this is really not anything that any of us want for ourselves or for our loved ones. And would that I had a cure, or would that we had a cure, and there's a lot of people working on that. But there's an imperative to keep looking for that, and there are people doing that. So if you're listening to me, these are a couple resources that you can go to online. If you don't have internet access, you can jot down that phone number. They've got a table for the Alzheimer's Disease Association here, that information as well, I'm sure. I got the phone number right. Yes, all right. And they're a fabulous organization and a fabulous resource for learning more about where we stand with Alzheimer's and what you can do to have the best possible experience with a really bad situation. And with that, I will open the floor to some